Hello, I'm Stuart Eglin, Director of NHS R&D Northwest. You're about to watch one of a series of films which we've put together to give you some indication of the kind of health research that goes on across the northwest of England. It's an opportunity to hear from some of the key leaders that lead the different health research organisations, units and centres and the like within the region. And what we've aimed at is to find out a little bit more about what goes on in those organisations and some of the stories and narratives that drive them. I hope you enjoy them and I look forward to your feedback. Thank you.
The consistent thing in my career, I think, has been I'm obsessive about inequalities, really. And currently my research is around the way in which the social and economic conditions of people's lives affects their health and generates really significant inequalities in health, which public health in this country tends to see as behavioural. So the dominant narrative is that people living in difficult social circumstances are in poor health because they behave badly. They smoke too much, they have terrible diets, they don't take enough physical exercise. Whereas actually those behaviours, I believe, are ways of coping with living in really difficult circumstances. And the primary cause is the fact that we live in a very unequal society where people have relatively low incomes, relatively poor housing, living in difficult places and without a lot of control over decisions that are made that affect their lives. So from very early on, really, whether it was research or policy or action, that's what I've been interested in, really, is those pathways from socioeconomic inequalities to health inequalities. And that I'm just passionate about it. So it's politics that have taken me into research. So Lilac is the Liverpool and Lancaster collaboration for public health research, and Liverpool University has a large department of public health, and they have a WHO collaborating centre for policy relevant research around health inequalities. Lancaster University has a very small public health group. It's my own group, really, and one or two other people who do work in public health, but they tend to work either on the health and social care side rather than the public health, the wider social determinants, or they're working on behaviour related things, which, as I've said, is not my thing, really. So Margaret Whitehead and I are friends. We know one another well. We've worked together on research projects, and Lilac came out of that friendship and collaboration, really. So in part, it was Margaret recognising that my interest in community empowerment and community initiatives was something they didn't have expertise in, and my recognising that actually having a link with this much larger, higher profile group was going to be very powerful for us and build capacity in both directions, really. Two things that I'm interested in is understanding what drives this lifestyle drift that we have going on. So why, when we have so much evidence from international and national inquiries that the primary causes of these dramatic differences in life expectancy and in premature mortality and in chronic illness are actually upstream. They're about the conditions in which people live, in which they work, in which children are born, people die. Why we've got all this evidence, we still persist to focus on changing people's behaviour. So it's almost like, and it's not a drift. I refer to it in the literature as lifestyle drift, but it's more like an avalanche, really. So people start off with this upstream story, and then they end up acting at the level of individuals. And I want to understand why. What are the drivers of that? Aristotle called it practical wisdom, which is the wisdom and understanding that we all develop on the basis of our experience of life, right? So in a healthcare context, it would be somebody who's lived most of their life with diabetes. And they probably know more about their diabetes than any clinician would ever know about their diabetes. One of the best examples of this is the AIDS HIV pandemic, where actually in California it was the people with HIV who were telling the clinicians what the treatment needed to be, and they drove that enormous change in clinical treatment for HIV. So this experiential knowledge or practical wisdom or lay knowledge it's experience based, it's checked out, so throughout our lives we're checking out whether this works for us, and I think it's an enormous resource for us in public health that we neglect, really. That it used to be that we talked about it as beliefs, just these quaint things that people had about culture, and that they were somehow divorced from fact, or whereas I think that this knowledge is a source of real expertise, and that if we listen to it, we might create interventions that had more chance of being successful. We might develop services which were seen to be more acceptable, and therefore they will be used more appropriately. It allows you to collect the data, and the methods allow you to systematically interrogate that data and link it to social theory in a way that allows you then to generalise from other groups. One of the prejudices against qualitative research is that you can't generalise from qualitative research. So you may do a very small-scale study in an inner-city area where people are living in really difficult circumstances, and the argument would be that the context there, the environment, is so different that you can't take your findings from that area and apply it to another area. And I think the misunderstanding is that with quantitative research you do that generalising on the basis of probability, statistical probability. So you collect from a sample that represents the population. In qualitative research, you do that generalising on the basis of theory. So you can account for why that pattern might apply in a different situation. The classic example, well, I think one of the classic examples of that, the power to do that, is Hilary Graham's work, early work on smoking amongst white working class mothers with children, where she was trying to understand why, even though they knew that smoking was bad for their health and they knew that smoking was bad for their children's health, they continued to smoke, because mothers generally are incredibly responsible people. So what she found was that they were using smoking as a coping mechanism. Right? So at really difficult times in their lives, they would use smoking and a cup of tea as a way of removing themselves from a really stressful situation. And her theory was therefore, she changed the notion of smoking as a health damaging behaviour to smoking as a coping mechanism.